everyone. We thank you so much for coming today. My name is Sandy Maslango, and we would like to welcome you in our session today. Last session, we had a wonderful session whereby we were looking on arthritis. So we are back today again to such a wonderful session. Actually, we are appreciating the support from our Indian team, for the support they're giving us to have time to share our best practices, information, and skills. So feel free to share whatever you want to share with us, and feel free to contribute as possible as you can. We hope others will join us along the way as we continue. So maybe for this time, then I give you the opportunities to introduce yourselves. Maybe I'll start with Cyprian. Mr. Martin, can you introduce yourself? Mr. Cyprian, yes.
Hey, hi, morning team. How are you this morning? Afternoon team, how are you? Hope you all fine.
Thank you, Mr. Messenger. Mr. Pennington, can you introduce yourself?
Afternoon, team. Pennington Lamini from Eswatini Hospice at Home, who is based at Shiselweni region.
Thank you so much, Mr. Lamini, for joining today. Tandazile at team, may we give you the chance to introduce yourselves?
Afternoon team. This is Eswatini from Manzini Government Hospital. So I'm the one that will be presenting on non-opioids. Thank you so much,
Emily, for joining us today. We are happy to have you. Maybe I will give our team the opportunity to introduce themselves. Start with our today's didactic presenter, Mr. Kelly.
Good afternoon, team. My name is Sabelo Kelly. Good day, colleagues. I'm Paz Pumayo, the Eswatini Hospice at Home team.
Good afternoon, colleagues. I'm Mercy Shabam with the Eswatini Hospice at Home Hub team.
Good afternoon, team. I'm Zoda Kamete with the Hospice at Home team.
Thank you so much. We hope everyone is here, and we hope you will enjoy the session. So, as I've said, you can introduce yourselves by writing your name and where you are joining on chat. We will appreciate that too. During the session, whenever you have a question, you are free to raise your hand, or you can also write your contribution or question on chat. It's also okay. So last time we had a presentation on arthritis, and we identified that this is one of the challenges and pain that we need to manage. And arthritis is not a temporal situation; it's a chronic problem. So we specifically addressed it because it's one of the managed pain, and sometimes we take it for granted. We even and yet arthritis can be diagnosed for more than. So today, last week we have Mr. Dlamini as our case president. I don't know if Mr. Dlamini, you have a feedback concerning your case presentation on this man who was susceptible to adhere to another stroke. If you can give us feedback, if ever we were able to meet that patient in these past 2 weeks, maybe you can share with the team on what has happened with the patient, any challenges or any successes you have had with the patient so far.
Thank you very much, Mr. Maslang. What I can say is that we have been able to visit the client with our social worker. Yes, the problem is still there, But now one of his brothers has just intervened in the matter, and then he promised that he will come back to the client and give a feedback as to how far has he gone with trying to solve the problem of the care claim. Besides that, the client is still getting pain medication, the pain is controlled, and since the pain is controlled, he has been able to sleep overnight, although that problem still exists. But so far, we're still waiting to get a feedback from the senior brother who volunteered to take care of the matter. That's all I can share.
We need to show us that everything is going well, and we hope the team advice is working. Actually, today you are giving us a testimony that we are not just sitting here to share, but we are helping one another to do better. The cases we are sharing are real patients, and so we help one another. Let's continue to support one another to ensure that we do better for our patients. Let me also acknowledge the presence of Ms. Tagazile, and together with the sister Twala. Thank you so much. You are welcome. You are also welcome to even share even by food. So today we'll be looking around on pain management. So last time we said that we will look at chronic neck and back pain. But when we are reviewing the information that we need to share with you today, we discovered that we will be robbing you of some important information and principles that you can apply to in terms of chronic pain management, especially for people with serious illnesses that we are dealing with. So we will be looking at chronic pain management, especially this time around. We will note that in the previous presentation, we looked around on pain management principles. So now we cannot leave these other troublesome type of pain, which is called chronic pain management. So we will be giving or sharing with one another the chronic pain strategies for patients with serious illnesses. We'll be looking at what strategies we can employ to deal with chronic pain. So in the next 4 sessions that we'll have, we will look around on chronic pain management and the strategies that we can employ in our different setups to manage this pain, because it's one of the difficult pain to deal with, especially if you lack the skill to deal with it. So we'll be sharing on how best we can do it with the limited resources we'll do. Then after this chronic pain series, we will then finish our pain page or theme with our professors from Uganda. So we hope you will also enjoy. For today, we have Mr. Lukele who will share a presentation on non-opioid therapies or interventions we can do in terms of pain management, especially the chronic therapies. So he will be treating us on non-opioid chronic pain management, on how best we can manage chronic pain without using opioids. So he'll be sharing on that one today. We hope you will enjoy it. May I hand over to Mr. Luke.
Thank you so much, Mr. Matlangu. Team, once again. I'll be taking you through today's presentation, which is the non-opioid pain management. So, in the interest of time, start our presentation by stating our objectives. That is to explain the biological basis of chronic pain. We will discuss the benefits of motivational interviewing in creating a trusting patient client relationship. We will also describe potential non-pharmacological and non-opioid treatment for managing chronic pain. Then we will also describe the non-opioid treatments for managing chronic pain. As our introduction states, we will look at two things. We will look at the serious illness, also we will look at the chronic pain. In definition, a serious illness is the health condition that arises that carries a high risk of mortality and either negatively affects quality of life or daily function and excessive strain caregivers. Also, the chronic pain, would say is a brain disease that frequently limits life or work and is associated with functional impairment, depression, anxiety, substance use, and also reduced quality of life. Okay, we can also see that behind chronic pain, there is biology. There is biology behind chronic pain, which includes sensitization, inflammation, downstream consequences, and also the genetic predisposition. So under the sensitization here, we look at the neurobiological mechanism that is behind the development and perpetuate the chronic pain. And it can be peripheral or it can be central. When we look at the peripheral under this sensitization, we can see that even if the inflammation is no longer there, but the pain will be felt or the pain will persist. Under the central one, it states that when there is no peripheral inflammation, but the brain is still hypersensitized to detect the pain. So under inflammation here, the inflammation of the nervous system tissue perpetuates the chronic pain. The downstream consequences, we can see that there is functional impairment, there is depression, there is anxiety, also there is substance use disorders. Then lastly, we see genetic predisposition, where there is a strong genetic predisposition to chronic pain. So there are factors here that are influencing the chronic pain. There is the biological one, there is psychological, and also social. So with these three factors that influence chronic pain, you can see that they exacerbate and they increase the perception of this chronic pain we are talking about today. So we can see that under biological, we can see age, as you can see on the board, on the screen here, there is age, there is sex, there is fatigue. When you feel this or when you perceive these biological factors or when you perceive these factors that persist in chronic pain, you can see that the pain can persist in that way. So under psychological, you can see that there is depression, anxiety, stress, also the major psychiatric disorder you can find under psychological. And also social, the health, the behavioral, the social isolation in family systems, whether there are family problems, in culture, racism can also exacerbate the chronic pain, stigma, marginalization, and poverty. So all these factors can influence the chronic pain on our patients. So the chronic pain, the end of chronic pain treatment, there are principles we have to dwell on. So this course covers the first 3 following. So under this, we see that there are 5 possible principles that we will cover, but today we will only cover 3. That is, we will cover assessment, build a relationship, and also the use of non-opioid therapies. The other two remaining ones will cover them as we go on to our other resolution that are coming. So under assessment, we can see that we have to do a proper assessment. The comprehensive pain assessment is the first thing. So assessment should include the pain assessment. So we can see that every consultation that we are making to our clients, we need to do a proper assessment. Even if it's chronic pain, even if it's other ailments or other conditions, we can see that the first thing, the most important thing to our clients to do is the proper or the comprehensive pain assessment. So we can say that, assessment includes the pain assessment, it includes the functional assessment, the pain management history, we also have to do that. Mental and health substance use history, we have to assess that too. The review of medical records, they also help in doing our assessments so that our care to our clients can be very effective. And also we assess the sleep history, the insomnia, hypersomnia. We have to assess that in our clients. Some of our clients experiences a lot of things, including these sleep disturbances. Someone can experience insomnia. We have to assess what is the cause of that. Underbuilt relationship, we develop trust through skilled communication with our clients and with our patients. We have to set concrete and specific pain expectations and personal goals with our patients. There are several important considerations here to build trust. One of which is addressing chronic pain, whereby we use non-stigmatization language and be aware of conscious and unconscious biases we may have. Number 2, there is patience. We need to help, but it will take time. We know that when we are doing this ongoing counseling, when we are building trust, it's not one day thing. We have to do it continuously. It's an ongoing assessment or ongoing service that you have to render to that patient. Also, we have to do partnership and optimism. Still, we are building the relationship with our patients. So let the patient know what, we don't let the patient know you are in this together and things will improve. Give the patient hope so that the trust, the relationship will be built. So as clinicians, we have to build a rapport with our patients. So increasing their awareness that disparities exist and take action to combat with disparities. We know so that to let the patient know that there are disparities that are happening in our facilities. Might be the bigger facilities, might be the baby facilities, but there are disparities that really exist in those facilities. We have to let the patient know that such exists in our facilities. So we have to strengthen their communication skills to effectively communicate with the patient across all cultures. So under use of non-opioid therapies, which is the third principle, Here we can see that the patient benefits from non-pharmacological therapy, which includes the physical therapy, massage, acupuncture, cognitive behavioral therapy, that is CBT, and exercise. Those are the non-pharmacological therapy. And the burden here, as we can see, as we are promoting this presentation, is that we start with the non-pharmacological intervention. Then we do pharmacological intervention. So which here, when managing the chronic pain, we start with the pharmacological one, which I just stated here, and also after that, we can try the non-opioid one, which is the pharmacologic and non-pharmacologic therapies. Start with it first, start with the non-pharmacologic, we start with the non-opioid, and we may, if the pain persists, we may then go to the opioid one, which is the last one. Opioids are not the first line therapy for pain. You have to note that on this. Then opioids work for some people, but their harms are real. You have to take note of that. Then we are not allowed to predict who is likely to benefit before initiating treatment. Clinicians here, therefore, must be aware of all the benefits and harm of opioids. Also, we have to look at the motivational interviewing when dealing with chronic pain patients. A skilled communication here is aimed at establishing trust in patient-initiate relationship. We have to remember that we mentioned that we have to build the relationship here. So we are helping individuals to change behaviors so that they can focus on positive things like adaptive coping mechanisms, which increase their level of physical activity or changing opioid misuse behaviors. That are the things that they have to focus on. So there are adaptive and there are maladaptive coping strategies that our patients do. So as healthcare workers, we have to recommend, or we have to encourage our clients, we have to encourage our patients to partake in adaptive coping strategies. So as you can see here on our screen, the maladaptive one, we refer them as the negative one, which is avoiding the physical activity, reduced range, such as not wanting to leave the house. Some patients, they drink more alcohol, hoping that the pain will go away. Some, they avoid social interactions. Some, they reflect about possible implications of pain, feeling helpless or hopeless. So, saying that as healthcare workers, we have to encourage adaptive coping strategies like getting fresh air, encourage our clients to get fresh air, going out for a walk, calling a friend or a family member. We have to encourage them to do regular exercises, positive statements like my future looks bright and I will deal with this pain. So we have also to encourage social comparison, religious coping using religious beliefs or practices to break through existential fears about pain. Also, there is pharmacological non-opioid treatments. These are analgesics, and that should be tried, that should be always tried prior to prescribing opiates. We mentioned on the previous slides that we have to do non-pharmacological first when dealing with pain or when managing pain. We have to do first with non-pharmacological, then or when non-pharmacological doesn't work, we have to do non-opioid treatment, and then opioid should be the last last intervention we have to do in order to relieve this pain today. So the non-opioid treatment for pain is extensive. This includes the NSAID drugs, acetaminophen. Also, we have adjuvants, other non-opioid treatment, which are corticosteroids, antidepressants, and anticonvulsants. Then the last one, there are topical medications, topical creams that we use when decreasing pain or when alleviating pain on our pain lines. So on our summary, colleagues, we can see that the prevalence of serious illnesses and chronic pain are high. So we as clinicians face real obstacles in providing safe and effective pain management. Also, managing chronic pain requires a trusting, collaborative clinician-patient relationship. So I've said earlier on that this is an ongoing process. It's not a overnight intervention, but it takes time to build this relationship, this rapport with our clients. And also the data tells us that patients benefit from non-pharmacological therapy for chronic pain. Opioids are not the first line therapy for pain. Also, the clinicians must be aware of both benefits and harms of the opioid. So whenever we are dealing with this to our clients, we have to tell them everything they deserve to know, because it's their life and their rights to proper care as we are doing them as their nurses, as their healthcare workers. So this marks the end of my presentation, colleagues. I think we will take this and go out there and do what we are supposed to do in a proper way, so that our interventions will be very effective to our clients. Thank you so much, colleagues.
Thank you so much, Mr. Mshanti. I hope you made it clear to what we need to expect. What I've taken from this presentation is that actually the fact that in palliative care we are dealing with serious illnesses, with this invention of medicine that we have now, technology, most of our patients, they are now living longer, and you'll find that they will be going through different types of pain. And this chronic pain is another of the problematic symptoms that they are going through. So we need to equip one another, because one of the things we need to recognize and appreciate in our lives is that indeed we are facing different obstacles that we need to deal with. And for us to be effective in managing the pain, we need to understand the obstacles that each and every one of us is going through. Then from there, we'll be able to deal with it, because it is there. And most patients, they end up feeling like they are used to it, yet there's nobody who can be used to pain. So that it feels like having a serious illness now is a ticket to have serious pain. What I've learned is that for us to manage chronic pain, without a good mutual collaboration or trusted relationship between us clinicians and our clients, we will not manage in managing this type of pain. Unlike chronic pain, but this one requires to have a trusted relationship. Let the patient trust us that when they tell us about their pain, we will believe them and we will need to work with them. They need to understand that we are not their Jesus, but we are here to help them to do better with their pain, especially because one of the things that are there is the issue of the spread of working around non-pharmacologics, the CBTs, the motivational therapies or interview, which works around. Actually, when we talk of motivational interview, that one it becomes the most played in terms of the team, because when we have social workers in our team, they play a major role when it comes to motivational interview, helping the patients to focus on what best they can do and to adapt positively. So we will need the psychologist or the skills of psychologists or mental health to deal with CBT, because without equipping ourselves to practice it, we'll end up not doing, because chronic pain is a long time. So they need to do. What I like about it, that the simplest definition of it, it's a brain disease. Once you talk of chronic pain, it's a brain disease. It lasts long, even if the pain is controlled. Sensitivity makes it to last long. So we need to help them to cope mentally. So that's what I've learned today. And that even though we've been taught that opioids are good in pain management, they are not the first line therapy for treatment of pain. So we need to try the CBT, the non-opioids like the NSAID, acetaminophen, and others. Then we can go to opioids. So thank you so much, Mr. Kelly, to share that with us. So I appreciate it, and I hope team we have learned a lot in our today's presentation. I don't know if you have something else to add or any question. Yes, I can see you, Cyprian. You can add or any question.
Yes, good afternoon again, Tim. I just want to ask some few questions and just to add something. In the cases of acupuncture, do we do it here in Swaziland? It seems like it's some people's culture, like the Taiwanese taboo, the acupuncture, because I've never seen it here in Swaziland, but I've seen it somewhere. And I also want to ask about aroma. I don't know whether you know aroma. It's some kind of a solution with a certain smell. It also contributes in the treatment of chronic pain. Like when after bathing the patient, then you just smear the patient with it's tropical. It's a solution. We just like umgcobiselo umumvu. And then that smell, that kind of smell, they said it's good in treating chronic pains. So I'm not sure whether we do have the acupuncture together with the aroma, if you can introduce it as a palliative care nurses. Thank you.
Thank you, Mr. CP. Yes, indeed, you are saying too that the topicals they work best. As Mr. Killer also shared that we need to apply those, and thank you for sharing that we also have a topical called aroma. I hope also the team is also noting that. In terms of acupuncture, I've heard that in Eswatini, some Chinese therapy group, they do provide. So I think Taiwan friends, they can provide. I've never seen it provided by Eswatini and other people in those spa shops. I've never seen it, but the Taiwanese people, the Chinese people, they do supporting that one. It's only that these are just selections that in case a patient says, I want to try things, you can look around the issues of the Chinese around the Zurich. One of our social workers in previous presentation said that it is provided around Gables Day. Oh, Mike, I has something to add.
Thank you so much, Tim. And the issue of aroma is usually available with physiotherapy. So they are the best people to guide on how to go about with the science that will help relieve the pain. If they are consulted, then share the information. Thank you.
Thank you so much, Mali, for that. I hope team are also getting that, also that. Actually, when we started this page on pain management, we mentioned that, you know, total pain requires an interdisciplinary approach. So we need to work together. And if we cannot provide it, let's refer the patient to that area or let's consult for more help. So it doesn't mean if we don't have a therapist, we don't have a psychology, it means that now we will omit that or we will deprive the patient the right to have access to that. Let's link and support one another. If we don't have a doctor, we will link with those with doctors. So we work that way. I don't know if anyone wants to add also on this presentation. You can write on chat, you can share by raising your hand. You can lower your hand, Mr. Cyprian. I don't know if, thank you. But in the absence of other people maybe who wants to share or maybe when we are continuing, let's be cautious in terms of pain management and let's do thorough assessment in our different facilities to identify pain, especially this chronic pain, because it's really a problem and we cannot get used to it. So let's apply these non-pharmacological or non-opioids therapies or strategies to deal with it. And remember, every time you approach a patient with chronic pain, that this is a brain disease, and there's a possibility of sensitization there, or the inflammation, or it's just because of a long-term being on that therapy, so they will experience certain pain. So then you will know how to deal with it. Actually, to me, it's more like the strength of chronic pain management, it's psychological, social, and spiritual. Then we can go for the drugs and other things. But let's build on that one, how the patient can change his mind to focus. If you're looking at the adaptive and maladaptive procedure, some patients will say, I have even stopped taking a walk, I even stopped moving around. They feel like being better, to be bedridden is the best way to deal with pain. That's a maladaptive strategy. Then we need to help the patient to move. And even building the hope of the patient, help the patient to see life in a different way through motivational interviewing. So you can do the tour, help the patient to focus life in another perspective, other than focusing on the chronic pain. Maybe for this time, I will give this opportunity to Elizwane, who will be presenting a case from Manzini Hospital. Palliative care department, a case for today. And can I give you the opportunity to present? I hope we will share the screen on this side.
Good afternoon, colleagues. Yebo, I'm Enizwane from Manzini Government Hospital, Moneni. So I'll be presenting about I'll be presenting the case on opioids, and then this patient that I'm going to talk about is a female, which is 43 years old, with a diagnosis cholangiocarcinoma. Her chief main problem is that she has been complaining abdominal pains, body weakness, and fever for 2 weeks. Okay, the pain has been very persistent, and she was also complaining of chest pains. Okay, and on assessment, the patient on palpitation, there has been abdominal discomfort. Then the pain assessment, the duration of the pain has been 2 weeks with colic pain, which lasted for almost 3 days after taking the medication. Okay, on the part on precipitation factors, it has been food and movement. Then on relieving factors, the patient had to rest. And finally, she didn't have any problem when sleeping. She didn't complain. She was able to sleep. Okay, she was also able to walk. She didn't have any problem after she was taking the medication, the Al-Jaza. On intensity, the sickness actually started in December 2022. She was complaining of the abdominal pains. Then the scale of the pain has been from 6 to 7. Okay, so it has been from moderate to severe. It took her a month. On examination, the patient has a abdominal distended. Then she took Panadol, ibuprofen, and omeprazole. Okay, doctors gave her a morphine which she didn't tolerate. Then she had to take Panadol and ibuprofen. Oh, okay, on the surgical history, the patient had the cholangiocarcinoma, DVT, anemia, pelvic ulcer, which, as I said, started in January on the 19th. That is the date which she was referred to our facility. Medication, the relevant past medication has been Panadol, Tramadol, aspirin, and omeprazole. Then the current medication is only the Panadol and the ibuprofen. Social history is that she works full-time as a teacher. Her social economic class is a middle class. She's also married. Her lifestyle habits is reading. Relevant health conditions in the close family members, she said she's in good relationship. Okay, with advanced directives, the DNR has not been done. Fine, living well, she's still willing to live. That's why she's able to honor all the appointments when she's supposed to come for reviews. Or on the comments, she's still coming. We always advise her to honor the appointments, and she honors the appointments, and we give her counseling, which she appreciates a lot. Okay, my vital signs, temperature is 35.3 degrees Celsius, CPP 125.81, pulse 100, respirations 16, then SPOs 98%. Then the pain score is from 6 to 7. It was from 6 to 7, but now it's 3 to 4. Okay, from initiation, the pain score was 1, dyspnea 3, anxiety 1, agitation 1, depression 1, fatigue 1, nausea 0, anorexia 0, constipation 1, dry mouth 0, or pure mobility, mobility says 1. Okay, lab results. The full blood count, the result was 6. It ranges from 12 to 15, and find she was transfused. Then creatinine, the result was 48. The range is 53 to 97. Urea, the result was 3.1. Then the reference range is 2.9 to 9.3. Okay, the further plan is that since she's unable to even go to church, then she had to ask the church members to visit her for prayers. Then, and also for step 1 on pain management, or for pain management, and also to continue with the counseling to her and also her family. And lastly, to also continue receiving her chemotherapy. Thank you so much. That's the end of my presentation.
Thank you, Ms. Ali. We hope the team has captured the information concerning this patient. Actually, maybe to mention, team, is that cholangiocarcinoma is the cancer that has to do with the bile ducts. So it's just inside there where there is bile secretion in the body. So it's the cancer of those ducts there. So this is this patient. I don't know if you want to add something.
Good afternoon, Tim.
Yes.
Yes, probably before you, the rest of you add something. I think like you have rightly outlined or clarified what cholangiocarcinoma would actually be. In simpler terms, yes, it's cancer of the bile duct. So you would probably expect the liver to be affected and some other internal organs. So when actually dealing with pain for clients like such as these ones, then you might need to consider visceral pain. Unfortunately, I don't know how it happened. I think we are set to default that whenever a client reports whenever a client reports moderate to severe pain, then we think opioids. Unfortunately, some of our clients, we find that they don't tolerate the opioids well. Then we go down the who steps of pain management. So I think ordinarily we should have started like with step 1 and upwards, but probably because the client was already complaining of was at the moderate to severe pain, probably that's why the doctors decided to start with strong opioids. However, while we were managing the clients, like I said, we had to be cognizant of the fact that it could be visceral pain. So then we had to also consider the fact that she's not tolerating the strong opioids. Then we had to tap down. At some point, she was put on weak opioids plus paracetamol, which she did well with. Then again, we had to tap down to NSAIDs plus paracetamol. We feel she's doing better with the NSAIDs, which is step 1. For now, we decided, okay, let's keep her on that and review her on the next visit and see if the pain will be controlled on next visit. If not, we may need to consider adding either they call them gabapentinoids or a tricyclic antidepressant to deal with the visceral pain together with the NSAIDs and paracetamol. Otherwise, I think most of the details she has highlighted, but also to mention is that usually amongst other symptoms with cholangiocarcinomas, clients will be reporting whitish stools. So then they would definitely come with anxiety and all that. And we had to attend to issues of anxiety, how to cope. We had to give information why everything is happening this way, which to some extent it actually assisted because the clients got to understand why everything is happening this way. But also we had to employ other strategies like relaxation or distraction. Find something that will probably distract her, not to always think about the pain. And also, usually they say with anxiety, deep breathing exercises, they work very well. So we advise the client to do deep breathing exercises, but we haven't got a feedback as yet. Otherwise, we are yet to review the client on our next visit and see if they improve. If they do not improve, like in terms of pain control, then we may need to consider adding either a gabapentinoid or a tricyclic antidepressant. I think from this side, it would be that. Thank you so much.
Thank you so much, colleagues, for taking that advice. May I also continue to urge you, team, that you also need to help us improve in this session. So they have already shared our feedback session in our platform. Already there on chat, it is there. You can click it and share your feedback with us. Maybe also to open up for anyone who wants to ask anything from the hospital or add on how best they can manage this patient with liver-related cancer. I see Secret. I don't know if you have raised your hand, sir.
Yes, thank you, Mnguni, for your presentation. It is quite informing, but I think I know this client. A teacher, or it's similar, or maybe it's a client with a similar condition, but I'm just worried about the white blood cells because the pain there means there is an infection somewhere, somehow. So how bad or how high are the blood cells, the white blood cells? Because according to me, if the white blood cells are up, the patient cannot continue with chemotherapy. As well as if the HP is very low, the client cannot continue with chemotherapy. So how far are we with teaching this clients about the next section? Because I think for me, it's important to let the patient be aware that if the cells are up and if the BP and if the hemoglobin is low, he won't be able to continue with the next chemotherapy. I guess this client is on a cycle 4 or 5. She started on capacitarbine, if it's the one that I know, and at present she's no longer on capacitarbine because it was out of stock. Now she's on cyclophosphamide, if it is the one that I know. So for now, I just want to know if the HP is within the normal range. What about the white blood cells? Are they in the normal range? Then what is it that you are doing for her to make it within the normal range? Thank you.
Okay. Okay, the rest of the team will assist here. Okay, what normally happens for every client when we initiate the site, we go through all those discussions. We explain to them, let's say, each time they come for their sessions for each cycle, before we even do chemos, we will have to do blood results. We will have to do bloods. So we don't start any client on chemotherapy without knowing how their bloods are, including your white blood cells, including your HBC. That is why at some point, nurses on here mentioned that the HB was a bit low and the client was transfused as well. So even if we have neutrophilia, then clients will actually know that probably there is deranged white blood cells or neutrophils or whatsoever, and it will be communicated to the clients. Usually what they normally do, they give Nipogen. Unfortunately, we've been out of Nipogen for quite some time, so some clients do buy and all that. So my team here, they're still checking the white blood cells, but if there was anything to mention about the white blood cells, I think she would have, actually, okay, they're still checking. But usually we don't give chemo. If there is any significant lung that we need to consider, we wait and work around adjustments before we continue with the chemotherapies. So with the white blood cells, again, if they're high or low, if they're high, we give antibiotics. If they're low, then we give Nipogen to take them a bit up. So obviously the doctors would consider that. Even though I'm not getting the, okay, yes, at some point she had the white, like high white blood cells. And the assumption is, because it's even circled here, the assumption is the doctors attended to that. There is no way they can continue with chemo without checking, be it your renal function, your liver function, your differentials. They check everything before you continue chemo. And that is explained to the clients, because sometimes they come and they are told, okay, we won't be continuing with today's cycle as scheduled because of A, B, C, and D. So yes, we walk them through that. Thank you.
Thank you, Matsenja, and thank you, Chandazi, for clarifying what is happening in the patient. And I don't know if anyone wants to ask or add on how best we can move anything we feel like we need to cover for this patient. Even my team here, I'm looking at you. We can share team how best we can help, or anything we want to understand from Manzini Hospital. Nakona team was asked. All right. I'm seeing nobody's asking a patient. I'm hoping they're saying everything is good. I don't know if Manzini Hospital you have any patient for this team, because they don't have a patient, so maybe you should. It's not a shame. Okay.
Thank you, Tim. It is worth appreciating the efforts and the work that the team has done for these patients. Sometimes when you think of pain, we always think of the strong efforts, but it is appreciated that they are managing the pain as per the assessment and the feedback they are receiving from the patient, which shows that it is more about the patient and the feedback, as much as they have the information, but it is appreciated that the patient is in the center of the care, and we hope the patient is also appreciating the support she is receiving from the team. Thank you.
Thank you. Anyone else team wants to say something to Manzini Hospital? Otherwise, this was a great presentation and it's a challenging case. I think I wanted to ask on what stage is this cancer now? I wanted to ask, but I don't know if you have something, because I saw this one is a 40-year-old woman. I'm saying woman also. So I don't know, family history related wise, have you managed to find out in terms of to identify the immediate support system for her?
Okay, Sorry, okay, I think the second part, nurses will be able to take it. But in terms of staging, she is actually stage 4 because there's according to the CT scan, there's involvement of the liver, there's tumors around the liver. So she's currently stage 4. But then at this time, it wasn't clear whether is it a secondary lung or it's primary lung. Otherwise, there is involvement of the liver, which is why there is probably that abdominal distension. That is why there is probably the liver involvement, which may lead to. That's why we thought visceral pain. There is also involvement of, we're not sure what caused the pleural effusion because she also has pleural effusion. So on presentation, there was that distension. There was also shortness of breath and stuff. And yeah, but whether the involvement of the liver is as a result of primary disease or secondary disease, they are still not sure. But yes, there are tumors in the liver. And in terms of support, mainly it's the kids, because when she came the very first time, she was with the kids and a sister, but
You are mute. Please unmute yourself, Tandazi.
oh, sorry, you touched that by mistake. So yes, the support system currently that she has, it's the kids. Yes, on their initial visit, there was a sister as well, but most of the time she's with the kids. The husband died, and she was someone who was actually actively involved in church issues, but then because of the current condition, and she's no longer able to attend church as well. That is why we emphasize that if she could get people she trusts and people close to her to continue nourishing her spiritual aspect of life.
Thank you so much. I think with that information, I think the team is that getting things that are maybe clear. My advice can be that in such a situation like this, team, if we are hopeful of what the military chemo can do, but you know the engine of every medication is the liver. Even if it's the chemo, for it to go out of the blood, you know, we rely on the liver. And such patients, when we initiate them either for Panado or NSAIDs, we need to be very critical on their liver and the kidneys. So I'm happy that you are able to continue to do the bloods, continue to check them, because these 2 drugs that she is already taking now, they have significant effect on how the liver will look like in a certain days, in a month or so, and how the kidneys will function. So look closer to those issues when we are giving them, especially the NSAIDs and these drugs and other drugs, including the chemo itself. So I maybe we are going to do that. So when we are managing, always weigh around the outcome. I don't know if you have sat down and determined the goal of chemo. What are we providing it for? But I'm hoping you have done that. If it's for curative, that's great. Hope. But then the oncologist is the best person who can advise at this stage now, if it's stage 4 and how much damage it has caused, and then on the damage that has been caused, and how best can we make this patient cancer-free. Thank you so much to do that and continue to eat so much. It will help. But what I want to say is, if then the goal of the chemotherapy she is going to is for now palliative chemo to just handle the cancer not to move, please sit down with her. I don't know how old are the children. So you have this goal of care to be clear that now she is at end of life. So enroll the patient to end of life as early as possible, so that now she can begin to shape the way very well, because they end up getting disappointed. They feel like it's now unnecessary to go to the chemo. While as healthcare workers, we are happy to see the patient survive a little bit longer, enjoying life, and she would become hopeless because she was expecting the chemo to kill all the cancer cells, yet the different goals. So I would say, in your discussions with the patient, you have those goals of care. This is a mother, you will find that she is a sibling to other people. And what's their role? Like the family organogram, if I'm not in the sense of enrolling an aggressive social worker there to ensure that when the patient the time to die, because now we are clear, as a team we know death is something we cannot stop once advanced. It's something that can happen. We can have the patient for a longer time because of the particular people, but we are now sure something bad will happen. So to take the patient through end of life care, it will help you and help the patient to have a good time with the patient, the children and relatives, and have time to take care of herself and be able also to finish very well. So I'm saying in your goals of care discussion, let it be clear what is the purpose of the chemo for her, so that she can make certain decisions concerning her life. Even spirituality, now she is not able to go to church, how best then you can support the patient. If then there's a need to consult those bazalwane, even asking the patient, does she not blame anything towards herself to have this chemo, to have this cancer diagnosed now and reported stage 4? Because they end up saying, we have one patient who has told me that she blames herself, that she was in the health sector and she was aggressive and encouraging people to do checkouts and everything, but now she has this type of cancer and it's advanced and she don't know what to do and she feels that she has let down herself. But when we're talking with her, you find that the patient has done all she could do, but then the cancer did what it could do. So I think the counseling you need to do it there, and the coping mechanism, other than maybe focusing on the chemo and other things, let's build up the supporting system of this patient. I don't know how old are these children and what perception they do have. What I've learned is that now these children, especially these single mothers, the mother is the Jesus, is everything that they are left to do. So if then we neglect them and we know the mother at some point will go, we are depriving them this opportunity to cope and find a way to live positively and expect the bad news to happen at any point in time and be able to survive too. So I think also building around those issues, but it starts with identifying the purpose of the stage of the disease and the purpose of the chemo. I'm not sure how far you've gone in that area, but having those psychologists will help you, and having the social workers, they will help you to go an extra mile than the chemo, than the drugs that the patient is receiving. You will be able to cover all those other areas that are needed at this point in time. Otherwise, you will have a patient reported to have passed away, and you will discover the children will be scared of cancers. Actually, even the issue of how did the husband die, and how does the woman survive after the death of the husband? Building those relationships. This woman might be going through chronic pain, physically, psychologically. So please, if possible, dedicate that time to help cope that way. That would be my intervention. Otherwise, even for pharmacological management, I would say come closer to monitor the electives and the KMTs. It will help you easily identify if these NSAIDs and that are working very well for her without causing any problems. Otherwise, those are the issues I will share. Even if it needs to be, link them with your home based like Hospice, they will help them. Because some patients, they will find that they are not able to open up in a facility, they prefer someone who come home. So those things, working together as a team, you will find that you achieve more as a team in helping this patient. Not alone him, even others. You will find that as a facility, you cannot have that time to build on the psychosocial aspect that we might be facing. You will end up monitoring the symptoms. So also engage these teams, they can support you in managing this patient. That's what I can say for today. Thank you so much, team. I don't know if I'm leaving someone behind. Otherwise, we will have another session on the, I don't know if I'm leaving someone, anything on a Manzini Hospital. Otherwise, that was a great presentation. Actually, is a great case. If it was me, I would say in our next session, please bring this case again, but I cannot say that. Because the visit of the patient are determined by the needs and they're determined by the schedule. But this was a great presentation from you team. I really appreciate that. I don't know if you want to add something or you want to ask the team anything concerning this case or anything you want to ask from us. And I give you this opportunity now before maybe I sum up and then we close. Okay. I take that as something you have laid today and you have also learned. Thank you so much. Thank you so much, Zita. I want to introduce to you, team. I've already shared with Tandazile and I've shared with TCB. I've shared with also Sister Felicity. Next time I will come closer to Mateo at some point to request him to support in terms of case presentations. So we have tried to update our case presentation. I did share it with Sister Twala from Mateo Hospital too. I don't know what happened between Swane and Sister Twilight in terms of the case, but what I can say is we have a case presentation that is so similar to speaking with detailed information. So anytime you will need it, I've shared with you because we have shared many times case presentation, so you will have the copy to share the case presentation. But anytime we will request it, we will request you to use our new template. It's very straight and easy to fill than this one. So we hope it will help us capture more detailed information in our next presentations. Our next session will be on the 16th of August, and we'll be looking at how to we prescribe opioids for this chronic pain patients. So we'll be looking around the track. We did look around chronic pain, so we'll be just polishing it up now specifically for patients with chronic pain. How are we going to prescribe? How do we go around prescribing opioids? Looking at these are brain disease patients. So how do we go around even monitoring issues of addiction? So we'll be looking around those issues, but how to prescribe opioids for chronic pain and management. Thank you so much, team. I don't know if I'm leaving anyone. Otherwise, let's meet on the 16th of August. May I encourage you that you take this seriously and look close. Around in November, we'll finish this batch, then we'll release to you our batch test. And then once you fill those batch tests, you will receive your ECO Hospice INDA certificate. So we will take this program seriously. Then later we will have another page on symptom management. Thank you so much. Bye-bye. Let's meet on the 16th. Remember to click on the chat before exiting, please. There's a feedback link there. Please click it for us.